A new day begins in a small rural town in South Africa. The primary healthcare clinic in the main street is an enthusiastic participant in the country's massive health reform program, which began in 2009. The ultimate goal of this reform is the establishment of National Health Insurance, or NHI, which is to provide universal access to quality healthcare free at the point of use by the year 2025.
At the moment, we're concentrating very heavily on the quality of healthcare in the public sector. So we said, let's listen to our people on the ground. If people are sitting in taxis, at church, or in social activities and are complaining about the public healthcare system, what are they complaining about? What is that which will be bringing to the fore? And we realize that it will be things like availability of medicines. It will be things like waiting times. It will be things like the attitude of staff to them as patients. All those we put together and say, when we pilot NHI, we are looking at them.
Lady Brand Clinic has been selected as one of 11 ideal clinics that are situated in the NHI pilot districts. Lessons learned here will be applied across all of the 3,600 primary care clinics in the country.
It all started in 2013 when we were introduced to the SARRAH team as a support team. So they have been supporting us through and through. Sis Miriam, this is a new sign put up. It's one of the renovations done.
This is one of many initiatives supported by the SARRAH program, which aims to strengthen the national response to AIDS and health. SARRAH is funded primarily by the UK's Department for International Development and managed by the health agency HLSP. Today, a SARRAH consultant is visiting the Lady Brand Clinic to hear how the work is going.
This is very good because it's in different languages.
Exactly. We bought some new equipment in this clinic. We repaired some of the things in this clinic. The generator outside, even the water tank, everything was left working.
The SARRAH team take initiative and they help us a lot, really. They push us and they come up with a list and say these things must be done, and we try our best.
In preparation for NHI, the government is contracting private sector doctors to work in the clinics, which are currently run by nurses. The GP contracting initiative is funded mainly by the European Union.
We really need doctors in the primary healthcare setting because of there are so many things that we pick up as the doctors that may be missed by the nursing personnel, that we can maybe advocate for the patients to be seen at another level, at a higher level.
Having a doctor in the clinic can also prevent unnecessary referrals to the hospital, as well as saving patients the time and money they spend traveling to get there.
I don't want this clinic to be the only clinic, say in Manzupa, that has been worked on. I'll be happy if we can do other clinics to be like this one.
The ideal clinic and GP contracting initiatives will go a long way towards strengthening primary health care. The Department of Health is also re-engineering the primary healthcare system. Teams of specialists are mentoring and overseeing clinics in all health districts. 2 new programs are taking health closer to the community. Mobile clinics screen and treat learners in underprivileged schools. Outreach teams of community health workers visit households across the country. SARRAH has supported the development phase of many of these initiatives. Every day, trained community health workers leave the Lady Brand Clinic to visit households in the local township. In time, these outreach teams will operate in each ward of the country.
Good day. Uko wa kwanyana o exercise o kopota pot.
A ke le hola o no le teng ke la ka o botsa ka gana ke tswa kae ka mo.
Ka ipotsa ka ga o le moka. Jo
Community health workers do basic health education and screening for HIV and other infectious diseases. They also care for patients with chronic conditions like diabetes and hypertension.
Mara go betse jwa.
Ke go betse hantle.
Oh. Ana mathata. Mona ke slow case. I don't know metsi.
Ke ano a holo metsi
Mona
ke
ke
ano.
lasix.
Most days, the outreach teams visit mothers with under fives to check on the children and give advice and support.
Ke nna mo ipone mosala. Ke hlahala lefapheng la bophelo bo botle.
They are assisted in this task by a new program using cell phones to enter information that goes directly to a national database. This mHealth or mobile health program is a public-private partnership between mobile phone companies in South Africa and the National Department of Health, supported by the SARRAH program. From small beginnings in 2010, the South African mHealth program is now one of the largest in the world.
In my experience, the SARRAH program's contribution to strengthening and improving the quality of primary healthcare services in South Africa has to date been tremendous. We've been able to use the SARRAH program and the program's resources to really play a catalytic role in being able to test certain interventions, to pilot certain interventions very quickly in the field, to learn about what works, and so that the department can then plan for the future continuation of interventions that work.
These interventions are already bringing benefits to communities.
Ba tla ba ntlisetsa meriana. Ene ba ntse ba ncheka hantle jalo ka ntse ke shekwa tleliniking.
It's not just about improving services and basic facilities. There is also the challenge of ongoing maintenance of infrastructure and equipment. For 4 months, the SARRAH program funded this team of recently qualified clinical engineers to repair equipment in the clinics of the NHI pilot district of Tshwane.
I've got the defibrillator that's not working. Can you take it out? Firstly, we didn't have the pads.
You didn't have the pads.
Yeah,
It didn't come with the pads.
No, it didn't come with the pads.
When it was brand new.
No, it wasn't the brand new. It's a gift.
You run a basic check before you use it, like every day. Yeah. I can see that it keeps switching off.
Me, if I say it's not working, to me it's not working. I don't know.
Yeah, especially if you didn't receive any training or anything.
Yeah. So, sister, as soon as we get this machine working, we'll give you proper training on how to use the equipment.
This is the stock room. Okay. It's where we keep the equipment.
This industrious team has now been absorbed into the National Department of Health as permanent employees.
This is the broken equipment.
The cuff, just as I suspected.
After a busy day, the repaired equipment is now ready for use.
Thanks to Sia and the team, they are doing a very good job to us. When there was nothing, it was chaos, disaster.
I'm so happy to make such a difference because it's our purpose for doing this course, this specializing in clinical, so that our government doesn't waste money like this. So we're saving a lot.
Okay, but I've got cups in there that are working. I've tested them, they're not leaking.
Today, health inspectors from the newly established Office of Health Standards Compliance are traveling across the country to pay an unannounced visit to 2 rural facilities. This Office of Health Standards Compliance is an independent watchdog body which was formally established in January 2014. SARRAH consultants assisted the Department of Health in the conceptualization and establishment of the office.
Sanwana, after we have audited, you will start to put plans in place now to improve the whole thing. This is to try to bring back that quality of healthcare back in our facilities.
The inspection starts with a guided tour by the clinic manager.
This one is no longer working. Yeah, no longer using it because it's you can't test the sterility on this thing.
So what is going to happen there? What are you using now to sterilize, or you have to send them to them?
To Dundee.
Okay.
If they know that inspectors can arrive anytime and this is what they can do, they'll start waking up. And so it's early days, because only last month I established the board. The board must now start establishing that office and populating it. The inspectors were already trained while we were waiting for the act to be passed in Parliament, because they've already done 700 mock inspections just to practice way into really serious official inspections in which they will even write a report and action be taken.
A comprehensive review of the facility's policies and procedures is an important part of the inspection.
The age of the patient is critical because it has to appear whether it was a minor or an adult. The age of the So redesigning of a consent form is critical and include what is done to a minor.
While one inspector is coaching the clinic manager, another is reviewing clinical and pharmacy services, which are assessed against the national core standards.
That's 10, 20, 30, 40, 50, 60. Yeah, you've got 10 extra. We agree. Okay, diazepam, we'll look at it.
I need your referral network displayed on all service areas, up and down.
We may look at that one, but I don't think it's enough.
Patients are also canvassed for their views on the clinic.
This process will help me to run this clinic better, because as the clinic will be in future an NHI accredited site. So before being accredited, I have to meet all the standards required by the national core standards.
Yeah, we've come to the end of our inspection. So thanks again for this stuff and your attitude towards that.
I hope this office will come again. I think the standard will be much better than what they've found today.
In the past year, different teams of inspectors have crisscrossed the country conducting audits, which so far have covered nearly 15% of clinics and hospitals. The inspectors are all health professionals who have been rigorously trained in South Africa and the UK, training which was supported by the SARRAH program.
SARRAH, channeling DFID funding, provided us with assistance actually when we needed it. Government resources are designed largely to deliver established programs. And things that are new are quite hard to develop within that framework.
What are the key concerns?
Recovery room and management.
It's not applicable. Okay, it's fine.
Where the SARRAH program was a huge use to us, they accompanied a process in evolution and provided us with that kind of ability to learn. The nature of SARRAH support was really very, very valuable in that it was flexible, it was effective, and it accompanied our process rather than dragging us back.
When you hear that they're coming or they descend on you, you become a little bit shaky and nervous. But it is my personal perspective is that when you have such audits, it assists you to improve the care. For instance, we're in a deep rural area, but we aspire as an institution to give a quality healthcare to our clients, irrespective of the area that we are. So having these people coming in here and looking at us, but when they come here, they assist us to change the whole outlook and move forward as an institution.
Improving the quality of service delivery is a fundamental prerequisite for national health insurance. But universal health coverage promises that services will be available to all South Africans, rich and poor. And this means a new health financing strategy.
Many people who are well-to-do, who don't want to share with the rest on the healthcare finance system, will tell you that universal health coverage simply means strengthening healthcare. Away from the money, you can strengthen it. And, you know, if you look at the World Health Organization, they'll tell you that the healthcare system has got 6 pillars. One of them is healthcare financing. The other pillars is leadership and governance, access to medicine and other commodities, the health workforce, you know, human resources, health information system, healthcare delivery system, but there's also that part about healthcare financing system. So you can't ignore it, and it has been ignored in many parts of the world for quite a long time.
South Africa's hospitals are being revamped in preparation for NHI. Poorly performing CEOs have been replaced and new systems are being put in place. Here in the Kimberley Hospital Complex, asset management teams are at work, verifying all the movable assets in this facility and across the province.
Assets are investment in any organization. The assets that we buy, equipment, are used by patients, so they are for service delivery. And we need to make sure that we look after that investment right through the lifespan of the asset.
Poor asset management has been the cause of provincial health departments being penalized by the Auditor General. In 2011, on request of the Health Department, SARRAH contracted a commercial asset company to work in 3 provinces. This produced immediate results, as the former Chief Financial Officer of the Eastern Cape explains.
To hear that we got unqualified on assets, it was exciting for me. It's something that was unheard in the Eastern Cape for the past 10 years. It was a great improvement. So this year we then said we needed to repeat the same that I did in the Eastern Cape, because I moved with the experience from the Eastern Cape. And we then reprioritized funding within the budget, and we then got into the project.
There are other spin-offs of this project. The company has trained several hundred young graduates in asset verification, giving them their first experience of the world of work.
It helps me a lot because I have a child, so I can buy for my child. When she asks me something, I also help my mother with the school fees of my child, because I want also a better future for my child.
So the successful SARRAH-funded pilot has led to this project being rolled out in another province, paid for by government rather than donor funding. This is a case study in the way SARRAH works.
With this funding, UK Aid and SARRAH with HLSP as a management support, It has actually helped us tremendously in bringing different partners together, but also getting development partners to recognize that development aid is not just about coming to a country with a big suitcase full of money, but working in partnership with government, planning together with government, and executing in partnership with government and facilitating the implementation plans.
Well, the most obvious achievement in the past 4 years is the fact that we've been able to turn around the HIV/AIDS pandemic to an extent where life expectancy started improving in South Africa.
Hey guys, know your status.
Continue in the beauty, compromise, don't compromise.
Get tested. Hey ladies, get tested.
We now have the largest antiretroviral treatment program in the world, with more than 2 million people on treatment. The impact of this treatment program has been nothing less than fantastic. It has increased life expectancy from an average of 56 years to 60 in a very short space of time, and it has decreased infant and child mortality by 25% over a 3-year period. These are some of the most dramatic changes in public health that you will see. And you know, this is something that this country should be proud of.
Hey ladies, you guys know about the HIV awareness program? You guys can get tested right over there.
The other bit of good news is our prevention of mother-to-child transmission program. In 2008, transmission was at 8% at 6 weeks post-delivery. It's now 2.7%. And again, we've seen an impact on under-5 mortality and neonatal mortality.
HIV testing and counseling campaigns, such as the one being run by HAIDS at universities and colleges, have been pivotal in South Africa's success in reversing the epidemic.
We have been able to test 20 million people in 20 months, led by the president in April 2010. And the reason we did this is because HCT, or HIV counseling and testing, is a pathway both into treatment if you're HIV positive and into positive prevention, as well as keeping yourself negative should you test negative. So it's a very, very important part of the HIV response in South Africa.
SARRAH supported the launch of the HCT campaign. It also funds the South African National AIDS Council, which coordinates all participants in the national AIDS response. Over the years, SARRAH has helped to establish a well-functioning SANAC secretariat.
SANAC is a forum of government and civil society, but a forum can't really implement anything. The consensus view in South Africa is that we need a strong secretariat which then supports government and civil society to implement programs of the National Strategic Plan.
I know that many of you, of course, are worried. What happens from here if you happen to test positive? I still wonder why a human being can like to live with a virus in their bodies and not prefer to know about it. If you know your status and you happen to be positive, it's not a life sentence because, as you know, we've got good treatment these days.
Expanding the treatment program has been a major achievement, and there are plans to yet double the number of HIV-positive people receiving life-saving drugs. But getting the drugs to people who need them is an ongoing challenge.
We've scaled up our HIV program significantly with over 2.5 million patients now receiving treatment, the consequence of which is that supplies to facilities and consequently to patients have actually been a challenge in certain cases.
SARRAH has supported the Department of Health to develop a new supply chain model involving private sector providers who receive prescriptions from health facilities. They then dispense the drugs and courier them to pick-up points convenient for the patient.
There are over 35,000 patients that are currently collecting their medication through such a system. The idea is to expand this model, and in the 10 pilot districts, we anticipate over 500,000 patients that would potentially have access to this model with time.
Today, the Treatment Action Campaign is protesting at the slow pace of reform of the country's patent laws. Since its inception, SARRAH has provided grant funding to the TAC, the leading advocacy organization for people living with HIV.
Obviously, you don't expect civil society to fold their arms and relax. They are scared, and I think people must understand them. Here are people who live on medicines and drugs for the rest of their life. They depend on them. So if because of intellectual property, they don't have easy access to affordable drugs, to them it's an immediate life sentence.
We are putting pressure on the National Department of Trade and Industry Minister, Rob Davis. The discussion document has been finalized. It's already awaiting the discussion in Parliament and for the signing it into law. So he's been dragging his feet. We pay the price with our lives, which is uncalled for. Obviously, the South African patent laws are bad. They have been handling out patent blindly without looking at the possibilities that we can get access to better drugs in the long run.
International intellectual property law.
The TAC has presented officials of the Department of Trade and Industry with a memorandum of demands that must be signed today.
So now that the government is very willing, they still have their shortcomings. And this is where we come in. We are like the community watchdogs over government, making sure that they deliver what they supposed to deliver and protect the health rights of every South African citizen.
From organizations like the TAC and SANEC that provide advocacy and oversight, to programs that strengthen service delivery and financing policy, SARRAH has provided catalytic funding to a wide range of national initiatives to improve the health of all South Africans. Much progress has been made, and this progress will continue once SARRAH ends. The unprecedented commitment of national leadership to health reform will see to that.
Are you comfortable that we're going to be testing in front of everyone here? No challenges.
I hold a view that health is an integral part of development. I feel very passionate about that because I feel it could change lots of things in the country. Without a proper healthcare system, there will be no development. And that's why I believe the healthcare system has to be fixed. You want to know my status? Yes. No, it's my secret.